Welcome to the MedEvidence podcast, hosted by Dr. Michael Koren and Michelle McCormick. MedEvidence, where we help you navigate the real truth behind medical research with both a clinical and research perspective. In this podcast, we'll have discussions with physicians that have extensive experience in patient care and research. How do you know that something works? In medicine, we conduct clinical trials to see if things work. Now, let's get the truth behind the data.
Welcome to MedEvidence. Today, we are joined by Dr. Michael Koren. He's a cardiologist and CEO of ENCORE Research Group, and he's been the principal investigator of over 2,000 clinical trials while being published in the most prestigious journals. Dr. Koren is interested in studying the research of research.
I am. Thank you.
That. And Dr. Victoria Helow, welcome. She is a well-respected pediatrician, clinical research investigator, and practicing in the emergency room. So thank you for being here, both of you. All right, what's new with the flu? Let's go there, shall we? Because that's a big topic, I think, with the COVID and flu, and they really resemble each other.
It used to be flu was the old boring virus, but maybe not so much anymore.
Yeah, I mean,
what are you saying, Vicki?
Well, flu, we've had COVID, we've had this pandemic where everybody was hearing about COVID, and truthfully, the flu is a pandemic every year as well, maybe not as severe as COVID was, because of course we've had protection over the year from all of that, and that's the big thing we're involved in, is protecting. We did the COVID, that was the most recent thing we were involved in, protecting people against, and now we're going after that flu. We need to do that every year, and everybody's heard of the flu. Interesting things about them is they have a lot of similarities, and we're noting that more and more. As she said, I work in the emergency room, and interestingly, our COVID tests have a flu as well as another virus, RSV, that we can talk about another time, that we can test for. And we are seeing many people with flu and COVID, but different waves of viruses happen. And for a while we had COVID, and then we had flu, and then COVID got a little better, and we had a second peak of the flu. So let's talk a little bit about the similaries between those two viruses from a
you're bringing up a historical perspective, and as you know, I'm an amateur historian, so I can't help myself. But as Dr. Helow has just mentioned, there have been waves where certain viruses seem to be more lethal and or more benign. And so I like to remind people that in the 1918 flu epidemic, that was a viral epidemic that was way worse than COVID. And just to give you some sense for that, literally, this was a virus that was killing 7% of 18-year-olds that got it. Think about that, 7% of 18-year-olds. And we know that because of a famous analysis that was done back then where recruits for World War I in 1918 went to this military camp in Massachusetts. Mm-hmm. And there were about, as I recall, about 14,000 of them that were being trained to go overseas from this military camp. And there was a flu epidemic that occurred at that time. And 700 18-year-olds died. Mm. Think about that. 700 18-year-olds died out of 14,000. So that's a 5% mortality rate over the course of a month.
That's a lot.
For the flu.
Yeah.
So the flu can be incredibly nasty. And getting to Dr. Helow's point, the flu shares certain characteristics with COVID. And those characteristics are, it's an RNA virus. So it's a virus that has nuclear material that's RNA versus DNA. Mm-hmm. Some viruses have DNA, some have RNA, and both COVID and flu have RNA. They both have 8 genes. They're incredibly simple organisms. There's only 8 genes in these things, but it's enough to keep these viruses going and to do their work of infecting cells. And are
they the same 8 genes?
No, well, they're a little different. They're not exactly the same, although they have similar functions.
Okay, all right.
And you're getting to a very important point, is that one of the most important functions for viruses to survive is they need to infect human cells.
Okay.
And they actually infect human cells through something called the ACE receptor. So I don't want to get too nerdy here because we're just starting this talk.
We could go down a rabbit hole.
Yeah, we can. But anything like a virus can't get into a cell unless there's an entry point.
Okay, that makes sense.
Right. And so both flu and COVID, they have slightly different mechanisms to get into the cells, but they basically get into vulnerable cells using a similar mechanism or a similar entry point.
Okay.
So there's a lot of correlations between the two.
Yeah, but the other thing about that simplicity is, although it's only 8 genes, that simplicity lends itself to easily being mutated, and so therefore it changes. As we've heard with the COVID vaccine, we've gone through the wild type, and then Delta, and then Omicron, and then Beta, and all of these different mutations, some of which have been more virulent or stronger, more deadly, causing more illness, and the illnesses even vary depending on some of those mutations. Well, we've seen that same thing every year with the flu. I'm sure everybody's heard about, this year's flu contains this strain and that strain, and we're going to talk about that and how important that is in trying to make a vaccine to help all of this. And again, as simple as they are, they can cause severe disease. So we don't mean to imply that this is a simple illness and you can get over it quickly, because it's simply not the truth. And so, we've learned through these mutations that we need to keep on top of it. And one of the things that is important is keeping on top of it with a vaccine and trying to make a good vaccine. And the ways to help protect against it are to protect from getting sick, and then more importantly, if you do happen to get the vaccine, to keep from getting severely ill. So we're going to talk about 2 of the strategies of protecting from getting the virus at all, and then if you do, to not get severe disease.
And I'm going to point out another similarity, and also a reason that local knowledge is extraordinarily important when you deal with this. And that is because they can both mutate easily. Both flu and COVID can mutate easily. There's going to be changes over weeks. Mm-hmm. So what's true in July is not necessarily true in September. Mm-hmm. And we need people like Dr. Helow, who are in the ER, that are have their finger on the pulse per se, and they can say, hey, now we know we're seeing this type of strain. This type of strain is really nasty. And so we're worried more about the flu in September, and actually in August we're more worried about COVID because that's what we're seeing.
Okay.
So these things change fairly rapidly, and the knowledge of local physicians is extraordinarily important in terms of treating these things well and knowing what to look for.
Yeah, I always hear people say, well, I got the shot and then I got a different strain, so with the vaccine. So I see what you're saying about, is that localized?
Yeah, and it's just human nature. So everybody's talking about COVID, so you feel like crap, and you say, I must have COVID. Well, no. Dr. Helow knows that the last week it's been all flu, right, or it's been all RSV.
Okay.
Right.
And again, because these viruses spread like viruses,
right,
they will change fairly rapidly, and local clinicians will know what's going on.
Yeah. Did we see a drop in flu over the past few years because of the COVID pandemic?
We definitely saw a drop in the incidence of flu, partially because of the strategies that we were using for COVID, because COVID was a pandemic and it was in the news and everybody was wearing masks and using gloves and doing the COVID handshake elbow to elbow. We were decreasing the spread of viruses in general. And so we did see a decrease in illnesses in general. I can tell you the census in the emergency room plummeted, not only because people were scared to go there and pick up COVID, but because viruses weren't being transmitted to begin with. It was quite an interesting phenomenon. And when we had this little spike, I remember with the early part of this year when we had a spike in COVID, all of a sudden, all of the things that I was seeing were injuries in the emergency room because everybody went back to wearing their masks and taking protection. And some of the schools even went back to doing virtual. And so, for me, it's exciting to see that in the emergency room. But it was just indicative of how effective the mitigation strategy of protecting against spread helped to decrease the amount of illness of all of these viruses.
Oh, so do you think we'll see an at-home flu test? Like we have COVID testing at home. So if it comes out negative, but we're still feeling sick, should we go get tested for flu?
Well, the technology is there, and the question is deploying it and how practical that is. Mm-hmm. So do we expect people to have their RSV, flu, COVID, and parainfluenza virus kits and all lined up and figure out which one it is, or do you go to an urgent care clinic and get a panel?
Right.
So all these things are possible, but ultimately we'll have tested home kits that look at all the different viruses. Mm-hmm. And otherwise, you're literally doing a different kit for every possibility.
Right.
And it can get confusing. Well, I think my COVID test is possible. No, it was my flu test. No, it was my parainfluenza virus.
Right. I mean, if I test negative at home with my COVID test and I'm still feeling bad.
Right. And then, of course, the treatments are different. So if there was one antiviral that worked for everything, that would be easy. Just I have the virus or not. But in fact, there are different antiviral treatments for the different diseases.
Well, you guys need to be doing some research to
we got some work to do.
All into one thing.
Yeah, Vicki, we got to get working.
Right, doing those vaccines. But let's just talk about this whole idea of mitigation strategies, of things that we can do to protect. So mitigating something means trying to stop it or halt it or limit it. And so we know, like we said earlier, that the COVID vaccine, we learned lots of things about putting masks on and wearing gloves. Not that we learned them as physicians or people in the medical field, but the country learned them and the world learned them because they were in the news. And that resulted in a dramatic decrease in many illnesses, infectious diseases. So why do those things work? Let me turn it over to you, Dr. Koren.
Sure. Well, let's go into what the different ways of transmitting viruses are. I think it's a good learning point. And it's actually particularly interesting because, again, the history of COVID was such that there was a little debate about which is the most important transmission strategy. So from a broad perspective, you have something that's called droplets. And droplets are, basically what it suggests, which is aqueous liquid forms of substances that contain viruses. So if you sneeze and you get the stuff in the sneeze on somebody else's face, well, that would be a droplet, and that can cause infection. Then there's this concept of what's called aerosols, and those are much finer particles, and that was the concern of the CDC, Center for Disease Control. And that's why we're recommending wearing masks. So there were a number of early cases where people were in restaurants, especially enclosed-in places, and there was one person who was the index case. They had COVID. They were breathing and talking and making a fuss, and other people around the table got it. There's another example of that where there were choirs that were together, and one person in the choir got it, and they were singing and they were yelling and doing their thing, and all the people around them got it. So the CDC looked at those early cases and said, hey, that's clearly an indication that there's aerosol spread of this virus.
Okay.
And then there's something that's called fomite spread. And fomite spread is when you actually get the virus on a substance and then somebody else touches the substance. So that's the whole concept of handshaking, which is a focal point for me because I think of the three, that's the one that has been least discussed in the U.S., but ironically, the mode of transmission that was the biggest concern in the very beginning of the World Health Organization.
Okay.
So interestingly, in Asia, where they were kind of more prepared for COVID because of their SARS experience, they were washing everything. They actually had machines going through the airport that were using antivirals and spreading them all over the place. And that seemed to be at odds with what the CDC was saying, which is just wear your mask and be careful about it and not focus on the handshake. So this is a little bit of an aside, but I think that's underappreciated. So, for example, I was watching President Biden give a speech a couple of weeks ago, and of course there are Secret Service agents around him, but I noticed that they're allowing him to shake hands with all these strangers, all these well-wishers after a speech. And I'm looking at him, this guy's a 79-year-old president. These handshakes could be more lethal than a bullet. And I was like envisioning the Secret Service guy jumping out in front of him and shaking hands for him so that the president has to shake hands with somebody.
Visual, yeah.
So, taking the bullet for the president, taking the handshake for the president. So anyhow, those are the three modes of transmission of these things. And there's a debate about which is more important, which is more relevant. But the fact is that it can occur all of them. So obviously, if somebody's sneezing, get far away from them. And that's the concept of social distancing.
6 feet, yeah.
Right. So even if somebody sneezes and you're far enough away, chances are you won't get enough of the virus to get sick. Wearing a mask, of course, is important, especially if you're in enclosed places. It's better to have interactions with people outside where you're less likely to have a concentration of the virus, just common sense things. And
wait a minute, let me ask you to clarify a little bit, or let me clarify a little bit, because we've had this whole big debate of, is the N95 necessary? Do you have to have a mask with oxygen?
Yeah, well,
and all those kind of things? And which one of those is going to be better for which mode of transmission?
Sure.
And a regular ordinary mask will help protect you from spreading it, giving it to somebody else. An N95 is protective not only of, spreading it, but of getting it as well, because it seals around. So the fomites are better protected. The other kind of masks are more protective against the bigger droplets. But any way that you can protect against that with a mask is going to be very beneficial. And that's important to stress because it has been shown that can be extremely beneficial beneficial. Not only that, but even the fomite spread. We touch things and then we touch our eyes, our nose, and our mouth. Well, if our nose and our mouth are covered, 2/3 of the mode of transmission is going to be limited. And although everybody says, well, wear gloves, and I've seen people wearing gloves and they're wearing them all day long, or they're wearing them for an hour, touching various things, but then they're touching their face with that gloved hand. So you need to understand how to use each one of these before you can listen to the media that makes conclusions that, well, gloves don't work. This person wore their gloves all day long. Yeah, that was the problem. So you got to make sure that you're taking them off when they become contaminated, or that you're using the right kind of mask, or that you are social distancing in addition to, or using an elbow-to-elbow COVID handshake. Wearing a glove and doing the handshake isn't going to help you if you're then going to touch your face with that gloved hand. And it's just such a pity that all of this has been in the news and so confusing to everybody.
I agree.
Yeah, and just to make it very simple, is wearing a mask will certainly protect somebody else if you sneeze into the mask, and will protect you to some degree. Wearing an N95 mask that has much smaller pores will protect you even more, because viruses can get through standard paper masks or cloth masks. So there's this concept of the recipient of the sneeze or the transmission versus the one that may have it that can give it to others. And then, of course, I completely agree that fomite spread is under-recognized. So wash your hands like crazy, in general, not just for COVID, but for any virus.
Yes.
Wash your hands like crazy and give the COVID handshake.
Yes, sir. Always. All right. So about the vaccines, though.
All right. So the strategies that we were just talking about are great strategies to help prevent the exposure and help prevent against getting that virus on you, in you, around you. And but we can't always do that. So we want to look at strategies that can help us minimize the amount of illness that we would get if, in fact, we got that virus in our system. And so we'll talk next about flu vaccines in general, and how we make them and how they work.
Yeah, and one thing before we go off that in terms of limiting exposure is to use a little bit of common sense. So I'm going to give you an example. I'm actually headed to some other town in about an hour, so hopefully the plane will be waiting for me.
It should be.
But my daughter calls me this morning and says that she has some sniffles. So we're going to actually visit grandparents. And so immediately I'm saying, okay, I have to make a decision. Do I put this person on the plane or not? And so I rushed right before I did this interview and got somebody to go to her apartment to give her a COVID test. The thinking being that if she has a positive COVID test, we'll leave her at home and not put her on the plane.
Right.
But if it's just a very low level virus, then we can probably mitigate that.
Yeah.
So
would she still wear a mask on the plane?
Absolutely.
Yes.
Yeah, absolutely. So I'm giving this as an example. These are practical things. So not only is it personal protection, but also think about the people around you. And knowing particularly for COVID is that older people are definitely more vulnerable, but there may be other people that have pre-existing conditions, or people haven't been vaccinated for things. I've had to get into this a little bit. I know that some of my daughter's friends haven't been vaccinated, and that's going to make me a little bit more concerned than people I know have been vaccinated in terms of the type of viruses they may have or their likelihood of spreading them. So there's some social elements to the mitigation strategy, and at least I advise my patients to ask questions. Who are you going to be around? It's a little uncomfortable sometimes to say, have you been vaccinated? Or it's a little bit uncomfortable. Hey, you're kind of sniffling a little bit. You feeling okay? But don't be afraid to make those observations. And even if you're sniffling a little bit, hey, good to see you, but I'm going to stay a little bit far away from you today.
Yeah.
And these are, it's funny because all these social pressures are to interact with people and to shake hands and whatnot. But if you have a smile on your face and you're good-natured about it and you say, we're all doing our part to protect the public and ourselves, then it's okay to have these conversations and still have a smile on your face and be friendly and enjoy each other.
Yeah, I was at the doctor yesterday, and it was mask required in the doctor's office. But when she came into the room, she didn't have one on.
Right.
And I'm like, okay, are you comfortable with me taking my mask off? And she said, absolutely. So,
and that's
have
great.
that conversation.
And that's a great example. It gives you a little time to assess things. So if two people are together and they're clearly both very healthy at that time and you're comfortable, you can ask to take your mask off. And I still would stay my 4 to 6 feet away. I'm enjoying my personal space
still the elbow shake.
And do these things. I think those are all just good general measures. But don't be afraid to assess the situation is what I'm really saying.
All right. So now, how do vaccines work?
Well, the way that vaccines work is the vaccine is given to you, and the body recognizes that, oh, I don't like that, and it's an enemy. And kind of like our military, it activates the part of the military that we need to kill this off. And so if we become practiced in an area of the world that there's snipers, what does our military do? It sends people who can kill snipers. If we're fighting a war in the water and there's submarines, we're going to send the Navy out and we're going to have them look for submarines. Well, that's what happens when we give vaccines, because different parts of our immune system, which is our military for fighting off our enemies, activate depending on what it is that is their enemy. So we try to figure out what part of each illness is the enemy. And as everybody's heard about this whole spike protein, we made a vaccine out of the spike protein components of the COVID vaccine because we could get to that. And when the body sees this spike protein, makes antibodies to those spike proteins, and then the next time a spike protein from the environment comes into our body in the form of this COVID vaccine, our immune system is ready to kill it off. That's the basis of how vaccines work, whether it's an injection, whether it's something we take orally, whether it's a smallpox where they made a smallpox sore on your arm so that your body saw it. The bottom line was it was exposed to that enemy and it knew what part of the army to activate the next time it saw it.
So to jump in on your military analogy, there are two types of immune cells that are important in terms of reacting to vaccines. They are called T lymphocytes and B lymphocytes. So T lymphocytes are actually they're sort of the spies that figure out who the enemy is, and they see who the bad antigen is, the bad protein, and then they teach the B lymphocytes how to arm the artillery to knock it out. So the B lymphocytes are the ones that actually create the antibodies. And so this is a process that takes you between 5 and 10 days once you're exposed to an antigen. So the key elements of developing the vaccines is to get those T lymphocytes to recognize the bad guy, and then as quickly as possible move that transmission to the B lymphocytes to create the tools that will actually fight off the virus. And the reason I'm bringing this up is because the different vaccines use different mechanisms. So as mentioned, the messenger RNA vaccines actually get into your body and produce the antigen. In the case of COVID, it's the spike protein, which is required for COVID to infect human cells. But there's other technologies. So we have the old technologies where you just take a virus and you kill it and you give that to a person. So there's lots of different antigens in that case. And then the different antigens are presented to the T lymphocytes. And they're not going to have just one precise bomb against the virus, but they're going to have a bunch of different antibodies that are created against the virus. And there's some debate about, is that better than being very, very tactical and just hitting that virus with the one thing? It gets even more complicated than that, because actually the messenger RNA is coding for about 2 to 5 things. But I won't get into that for this particular thing. It's something called epitopes. So there's actually different sequences within one vaccine, but that's for our advanced class.
Way over.
Yeah, that's for our advanced class. But getting back to the more simple things, so then you can kill a virus and that can elicit it. And then we have something, for example, the Novavax product that we work with here in Northeast Florida. And what that does is actually give person the spike protein that's genetically made. It's made artificially through fireflies and all these different mechanisms that they've created to actually create things outside of the body. And then once you do that, you give something called an adjuvant that actually presents that antigen to the immune system in a way that allows a very low concentration of the antigen to elicit a very large immune response. So there's a lot of really cool technologies that have been developed over the last 5 years, and we actually have them in the market because of the work that Dr. Helow and others here around the country have done.
That's awesome. So the flu virus or the flu vaccine, they always said it contains parts of the flu.
Well, there's many different flu vaccines, and the standard one that you're talking about is something that was known as the quadrivalent flu shots. And what they do is they grow different strains of the virus in eggs, and then from that take the virus and then kill it off a little bit and give it to you in a shot. And then there's ones that are grown in different kind of cultures rather than, like he was talking about, in a fly, not in an egg. And then other ones that they've kind of mixed up the components of it and, again, given it as egg-free. And one of the exciting things about COVID is we've learned so much about this technology where we can just, in a lab, make up just the messenger RNA, so we don't actually have to give COVID vaccine or parts of COVID vaccine. We can give the body the recipe for the spike protein, the recipe for COVID, the recipe for flu, the recipe for RSV, put it in the body, and then the body makes that little component. It doesn't make the whole virus. It makes a little component that he was talking about that the T cells can recognize as an enemy and activate the rest of the military so that the next time they see this in actual virus form, lo and behold, they can activate and we can generate an immune response to this. And again, these technologies have been amazing to become part of. And some of that technology, like he was talking about, wasn't just the messenger RNA where you can tell the body to make it, but these important things called adjuvants, which are a compound that's hooked to whatever we're giving that helps it stay in the body a little longer. Sometimes it's something that tells the immune system, hey, you got to get turned on, and it excites the immune system so you develop better response. So it's very exciting to me as somebody who's been in the pediatric world and very familiar with every way that you can make a vaccine and all of the good that has come out of vaccines. I'm old enough to remember many diseases that we no longer even have because of great vaccines. But every year we've had issues, especially in the pediatric patient population, with not having enough flu vaccine. And we've not had the flu vaccine because it's been growing in eggs. And we all know eggs contain salmonella. And lo and behold, these factories, one factory gets contaminated with salmonella, you got to shut the thing down. And now we're a year behind because unlike messenger RNA, which when he talked about mutations, we could change that messenger RNA in a moment's notice, basically. We can't do that with an egg that we've had to propagate and grow. And now we've produced a vaccine, as everybody's heard. Oh yeah, we're producing it with last year's virus. Well, you have to do it with last year's virus because it takes a year plus to grow it.
Yeah, so the manufacturing process for messenger RNA vaccines is much more efficient. And so Dr. Helow mentioned quadrivalent, just so everybody understands that. Quadrivalent means that there's 4 different strains of the virus that's being coded for. So quadrivalent, quad means 4, and valent is the different strains. So just to be clear, so we for example, a few years ago over at the research office, we looked at trivalent versus quadrivalent flu vaccines. And the reason that has been important historically is because we just don't know what strain is going to hit. And as Dr. Helow mentioned, when you're making vaccines in eggs, there's about a 1.5 year lead time to try to decide what strain is going to be in the vaccine when you actually have to use the drug, use the product. So nowadays, with this whole messenger RNA technology, we've accelerated that time process where we can literally respond to the newest strain within weeks. And we're doing that right now. We're doing studies right now with the latest and greatest strain of COVID using messenger RNA technology. And this was a strain that wasn't even known to mankind 3 months ago. And we have a vaccine already. So this has accelerated and created efficiencies in the vaccine processing and manufacturing processes.
Yeah, are flu vaccines only by shot? Or don't they have like a nasal one too?
They do. You want to talk about that?
It's all yours.
Okay. So like she said, there are flu vaccines, and what that is actually, like he was talking about, that they change it a little bit, that it's still alive, but it can't infect you to the degree that the regular flu vaccine can affect you. It's in the nose. The beauty of it being in the nose is you get incredible protection because it is really the whole flu vaccine, like he talked about, all of the different components, not just as we've talked about the spike protein of COVID. And so you get great response from that, and it's in the respiratory system, so those areas of the body become very protected. And so since we know that the viruses come in that direction, we have protection right where it comes
there's
in.
a little controversy about that.
Yes.
And I'm not, I don't know the data off the top of my head, but I know it's been discussed that maybe the nasal forms of vaccination aren't quite as effective as shots. So there's a little bit of a debate, but some, especially kids, probably don't like shots.
Don't like shots.
Right.
And that was one of the major motivating factors on creating that. I did some of the research with some of the nasal vaccines that, again, the motivating factor was the not wanting to have to get a shot, and it was good for early protection against the virus. But if the virus made it through those barriers, you didn't have as much body protection, if you will, to fight it off as you would if you gave a shot, is what some of the research that he's referring to demonstrated.
And then from a practical standpoint, as we know more and more about viruses, we have more and more means to protect people from them. Like, how many shots can we give people? Right. So as we said, there are literally dozens of viruses. Are we going to give dozens of shots? So the other way that the industry is moving is to combine things. So probably in the near future, you'll get your COVID, flu, RSV shot every year. And that will be coated with different valences. It may be pentavalent, or it could be whatever the number is for 13.
Yeah, right.
Trichodecaphobia valent.
Right.
And this is where things are going, so that you're exposed ahead of time to the most likely candidates for any particular season.
It's exciting with the new technologies.
We know with the two extreme age groups, in the pediatric patient population, we have a Prevnar vaccine, which is pneumococcal vaccine, and it has 13 strains in it. And then in the elderly patient population, you have the pneumococcal vaccine, pneumococcal 13, has 13 strains in it, because we know the most common 13 strains. Many of our viruses have many strains in them, and HPV, human papillomavirus, same thing. It's the most common. It was 5, and now it's 6, and they're doing studies on the 8 most common, looking to prevent against female cancers.
Yeah, this is starting to sound very complicated, so I think our next segment should go into personal strategies, so there's a take-home message for everybody.
Well, welcome back. Now, let's discuss the personal strategies for people. There's several different people have, yes, they're going to get vaccinated. No, they're not going to get vaccinated. But why should they get vaccinated against the flu?
I think it's a key question, though. The first question is, should you get vaccinated? And we talked about the mitigation strategies, avoiding stuff, but at the end of the day, everybody has to make the decision, do I get vaccinated or not? So what do you think, Vicki?
And the reason to get vaccinated, again, it does not prevent you from getting the virus. You will still be exposed to the virus, whether you wear your gloves, wear your mask, and do all of the mitigation strategies. So if, in fact, you do get the virus, what you need to do is something to help prevent from serious disease, and vaccines will help prevent against serious disease. We know that, again, from many, many years of using vaccines, 1918, and then we had the whole smallpox and a whole history of vaccines working, and a whole slew of them have been given to your kids and have been shown to work. The reason that you get them is, again, it's important to understand, not to prevent you from getting the disease, but to minimize the amount of disease, amount of illness, because these illnesses can cause devastating consequences from the illness at the time of the illness, as well as some delayed consequences that we now know of. Again, COVID has been wonderful in helping us get the word out to the general population of the consequences that can be felt well after somebody has a disease. And then also just lost time at work and school, lost time of income. And the other reason is because if you're going to decrease the amount of time that you have the disease, that means you're going to decrease the amount of spread of that disease, which is a community issue. And all of those are benefits that you can see by getting vaccines.
Yes, and that's a great point. So there are two elements to that decision about, do I get a vaccine? One is looking out for number one, so what your circumstances are, and two is being part of a community. And we know that when a certain percentage of the community gets vaccinated, we get to that herd immunity concept, where it's less likely to affect other people in the community. And then as far as looking out for number one, well, you need to look at your particular circumstances. So literally, if you're going to if you work at home and you do computer programming and you're a hermit and you don't interact with anybody else, well, maybe the risk of a vaccine, incredibly small as it is not worth it. you're going to be, you don't interact with anybody, and you are very, very unlikely to get sick. On the other hand, if you're a healthcare worker like we are, and you're in the hospitals, you're interacting with a lot of people, well, you better get a vaccine because your exposure risk is really, really high, even if you're very, very healthy.
Yeah.
So these are some of the thinking that goes into making that personal decision. What are your individual circumstances?
Right. And so we can talk about some individual cases. So what about an 18-year-old college student? Mine is actually going back to college this weekend. She's 21. Back in 2020, the first time I caught COVID was from her. I know it. So what are you telling, that population?
Again, that patient population, as you know, is they're big time into grouping. They're groupies, and they get close contact. They share drinks, and so they're the most important group at that age is the ones that are going to be going to college because of close quarters, and they're not going to wear masks and probably not going to worry about COVID handshakes. In fact, they're going to hug each other and drink after each other. And
I think it's been more than hugging.
They're hugging.
Yeah. exchange kisses and beyond. Exactly.
It's a family show.
Yeah,
they're hugging.
But and so this gets in the concept of exposure risk versus your medical risk. Mm-hmm. And so college students may have a low medical risk, but they have a very high exposure risk.
Right. Okay. All right. And how about, people who are out there working outside, maybe like a construction worker or someone working on paving roads, what kind of exposure are they looking at?
Again, they're not the hermit that's having minimal exposure. They're the outdoorsy, probably if they're a construction worker, they happen to be pretty healthy, and they may not be as much at risk, but who do they go home to at night?
Right.
Do they have young children? Mm-hmm. Do they have an elderly grandparent? Are they just working 40 hours a week? Many of them we know work 60 hours a week, which is taxing on the body. So again, they're going to benefit. I think certainly the benefit outweighs the risk, not only to themselves because of lost time at work, as well as to the other family members. So you get back to that community issue, as well as, again, the delayed consequences of some of these diseases that you may not know about at the moment.
Right. And so what I would say is this gets into some individual planning. So I would say that the vast majority of people in construction work would benefit from the vaccine, but there may be one or two that tend to have more significant reactions when they get a vaccine, and they may know that from previous years. Some people will have muscle aches and feel crappy for 2 or 3 days after they get a vaccine, and that could be a consideration in fairness. Mm-hmm. So if they are they're a type of worker that is not interacting in close quarters with people, they're outdoors, their transmission risk is going to be lower, their exposure risk is going to be lower, and then you look at your personal risk. And so if you're super healthy and you've had particularly bad reactions to vaccines in the past, I would be comfortable with making a personal decision saying maybe this is not for me this particular year. Of course, you also get into what's happening with the virus in the community, getting back to that point. And that's always a little bit unpredictable. Mm-hmm. On the other hand, for the vast majority of people who tolerate these things very, very well, why not? If you have a history of tolerating vaccines without any difficulty, heck, why not? Let's get it. Protect yourself, protect others around you.
So let's talk about our largest population. Those baby boomers, the biggest demographic, our elderly, the people that we're caring for. How do we either convince them that a flu vaccine is for them or not?
Well, I think the vast majority of them have received flu vaccines in the past and may actually be one of the easiest groups to explain the need for the flu vaccine, and especially with the newer technologies that we can have one that's going to be more effective, most likely, because it's going to be of a strain that's more recent than something from a year and a half ago. And so I think that group, again, not only because they probably have other family members that they can spread it to, including children or grandchildren, but also themselves. And that is the patient population that has underlying medical problems, that the flu can be devastating at the moment, as well as in a delayed consequences, especially for the lungs.
Yeah. So one of the interesting things about that is baby boomers will have a different experience with the medical system compared to younger people. So one of the things you can bring up is, well, we all know about shingles. Mm. And shingles comes from the fact that when we were growing up as baby boomers, when the chicken pox was around, The parents were thinking, okay, let's all get it and get it over with, and then we'll have herd immunity. Well, what the parents didn't know at that time was that there would be long-term consequences of these viruses. And we're seeing the same thing with COVID and other things. We just don't know the long-term consequences of these things. So doesn't it make sense to use the current technologies to prevent these viruses from getting into your body in the first place, or to minimize what happens if we get exposed to them?
Yeah.
And bringing up the shingles examples is something that baby boomers can identify with, because plenty of baby boomers have had the shingles, or they know somebody who's had the shingles and have had complications of that. And again, this concept of the long-term impact of viruses and reducing that impact is something they can understand.
Right. Okay.
But then there's always that argument, Dr. Koren, that I hear from people of, we don't know the long-term consequences of the COVID vaccine. Well, we do know the long-term consequences of the flu vaccine, and so far it's been very negligible. So what do you say to those people?
Well, we do know the long-term consequences of vaccines, like smallpox would be the best example of that. And interestingly, we had a campaign where everybody was getting smallpox vaccines, and it was so effective that smallpox was eradicated. And there's no data whatsoever that people that got that smallpox vaccination for year after year after year after year had any negative consequences of it. So there's actually a lot of information out there knowing that well-manufactured, safe vaccines are safe for people over the long run.
Yes.
Are you continuing to do flu vaccine research and trials?
Oh, absolutely. Yeah. Every year, the technology is changing. Right now, there's a lot of interest in using the messenger RNA technology for the flu, and we'll be doing studies on that. So we're excited about that. So if people are interested, give us a holler, and we can get you involved in it.
So in conclusion, the best way to prevent flu spread, we've talked about personal protection, getting the flu vaccine. What else in conclusion can we talk about?
The best way is to be a hermit and not and not to interact with anybody. But if you,
no,
yeah, this kind of gets old to be a hermit. I tried it, just didn't work out.
It doesn't work.
Yeah. So given that, obviously, understand how viruses are transmitted. Take personal protection measures, as we talked about, washing your hands, wearing your mask, asking questions of the people you're around, not being afraid to back off if somebody looks sick or is sniffling, and all those sorts of things. And then protect yourself with vaccines if it's appropriate for you as an individual.
Exactly. And yes, we are doing multiple flu vaccines, and even flu vaccine with RSV or flu vaccine with COVID, all of those different options. So again, if flu vaccine is something you're interested in, you can be a volunteer to participate in some of our studies, all of which will give you the flu vaccine plus or minus some other things. And so
and an insider tip. So interestingly, a lot of places will give people incentives to get vaccines. So if you go to certain drugstore chains or supermarket chains, you go in and they'll give you a gift card for $15 or $20 if you do that. And there's a little interesting nuance to that, because they'll often ask for your medical insurance before they do that, so they have information they can actually bill your company. So in a way, it's getting the money from the company and giving back to the patient, but I won't make any judgment on that. But what I will say is that in the research environment, because we ask patients to collect data for us, we'll pay you for that.
Oh.
And people can get paid $200, $300, $400, even $600 or $700 to record their symptoms after they've actually received the product. So it's a nice way of getting a nice little stipend and getting compensation for the time and effort you're putting in to help us move science forward.
Right, and that's at ENCORE Research locations.
It is.
Thanks for watching the MedEvidence podcast. To watch the rest of this series, head over to medevidence.info or subscribe to our podcast on your favorite podcast platform.